Good morning, everyone. Today we're beginning the first lecture in our Disaster Preparedness and Disaster Nursing series. This lecture focuses on leadership and coordination in disaster healthcare systems, and it provides the foundation for the rest of the course. When disasters occur, the healthcare system does not function the way it normally does. Resources are limited, infrastructure may be damaged, and the number of people needing care can exceed what hospitals and clinics can provide. In those situations, nurses often become essential leaders in coordinating care, making rapid decisions, and adapting clinical practice to difficult circumstances. Today, we will talk about what disasters are, how disaster response systems evolved historically, and how modern disaster response is organized. By the end of this lecture, there are several core competencies that you should understand. First, you should be able to identify the disaster life cycle and its 4 phases: mitigation, preparedness, response, and recovery. Second, you should understand the incident command system, often referred to ICS. Now, you won't understand it in detail because there is another lecture in a future module that goes into this in detail. So this is an introduction. But ICS is the standardized structure used to organize emergency response across multiple agencies. Third, you should understand the roles nurses play in disaster preparedness and response. Fourth, you should understand the principles of triage and resource allocation when resources are limited. We will also discuss special consideration, including unique needs of children in disasters and evolution of disaster nursing as a discipline. Now, all of this is an introduction to these topics. Later, as the semester goes on, we'll cover them in much more detail. So, some special considerations are to recognize special considerations of children in disasters, to explore historical evolution of disaster nursing roles, to examine federal disaster response systems, and to apply leadership principles. Before we talk about systems and structures, we need to understand what disasters are and how they unfold. A disaster is not simply a single event. It is a process that unfolds over time. Events before the disaster influence how severe the impact of the disaster will be. Actions taken during the disaster influence survival and injury rates, and long-term consequences continue well after the immediate emergency ends. Because of this, disaster management is often described as a cycle. What is a disaster? Let's talk about some definitions and types. A disaster is generally defined as a natural or human-caused event that causes more damage or casualties than the affected community can manage with its own resources. The key idea here is capacity. The same event may be manageable in one location, but overwhelming in another, depending on the infrastructure, the resources, and the preparation. Disasters overwhelm local resources, and when they do, they require outside assistance. They can cause physical or emotional harm, and they can disrupt normal community functioning. Some examples include natural disasters such as hurricanes, floods, earthquakes, wildfires, and human-caused events such as mass shootings, transportation accidents, industrial accidents, and acts of terrorism. The disaster life cycle includes 4 phases. Mitigation refers to actions that reduce the likelihood or impact of disasters, such as building codes or environmental protections and community risk reduction. Preparedness involves planning and training for disasters. This includes drills, emergency plans, the supply stockpiles. Response is the immediate phase after the disaster when actions focus on saving lives and preventing further damage. And then recovery involves the long-term process of restoring the community and addressing ongoing health needs. Nurses can play a role in every phase of this disaster life cycle. So disasters are recurring processes. They're not isolated events. Rickover said that we learn from others' mistakes. You will not live long enough to make all of your own mistakes. So this is why after a disaster ends, we do after action studies to see what we did and how we could do it better. I want to talk to you a little bit about history because I think history is important. So we're going to talk about civil defense and the evolution of nursing roles. And the roles of nursing have changed a lot over time. Disaster response systems in the United States evolved gradually. The first federal disaster legislation was written in 1803 after a fire in Portsmouth, New Hampshire. For more than a century after that, disaster response was largely reactive, with Congress passing individual laws in response to specific disasters. Then in 1950, the Disaster Relief Act created a more coordinated approach. And in 1979, the Federal Emergency Management Agency, which we now all refer to as FEMA, was created to centralize disaster coordination. The Stafford Act of 1988 established the framework that still largely governs disaster assistance today. But things continue to evolve. Homeland Security was created after 9/11 in 2001 and the terrorist attacks in New York City. And it centralized a lot of activities under the Department of Homeland Security, including FEMA. Early disaster planning placed relatively limited expectations on nurses. Nurses were primarily expected to assist in hospital evacuation and patient grouping. Over time, these roles expanded significantly, and modern disaster nurses must determine priorities, allocate resources, supervise teams, and adapt care under difficult circumstances. A central principle of disaster nursing is doing the greatest good for the greatest number of people. This can create ethical tensions because nurses are trained to focus on individual patients, but disasters require population-level thinking. So in the 1950s, in the civil defense era, there was this belief that military needs came first, and civilians and soldiers may be on the same battlefront. Regulations needed for allocation of nurses were essential. They actually allocated nurses like a resource. So the primary focus was hospital evacuation and patient grouping by nursing needs. Nurses at that time did not do triage. That came later. Then we have the expanded nursing competencies, so skills that disaster nurses should possess. They thought that nurses should determine priorities and evaluate conditions, identify personal needs and assess availability, assign, supervise, and teach effectively, improvise with limited resources, modify care without violating basic principles, and recognize changes and complications, and finally, make judicial resource allocation decisions. So, again, doing the best for the most. Some keys to nursing success were emotional readiness for overwhelming patient numbers, triage decisions, ethical preparation for resource allocation, expanded treatment roles, confidence and autonomous decision making, less qualified care providers being used. So nurses would be supervising untrained personnel, and team preparedness, understanding that the individual affects the entire mission. So it was really important for nurses to consider the ethical tensions between the responsibility as a family member and the responsibility as a professional. Some essential functions and assumptions during a crisis. Now remember, we're still talking about historically, so history. A fundamental assumption in disaster response is that the number of people that need care will exceed available resources. This means normal standards of care may need to be modified. For example, nurse-to-patient ratios may increase, documentation may be abbreviated, and supplies may need to be reused or improvised. However, core principles such as patient safety, infection control, and ethical practice, they must always remain intact. Catherine Sullivan, who is a nurse in 1958, said in a major disaster, the number of people needing care will exceed available resources, including staff, equipment, and supplies. So what does that mean to nursing? It means standardized peacetime care levels may be altered, that traditional nurse-to-patient ratios are impossible. Decision-making shifts to the population level outcomes rather than the individual level. And collective benefit is prioritized over individual optimization. Every nurse was considered a citizen first. So, know the warning signals of community disaster and community disaster plans, and maintain personal first aid and home emergency readiness. Personal preparedness is foundational today as it was then. So the belief then was very strongly emphasized that your RN credential was not enough. You needed more than that. So what does modifying care mean when there's not enough? And what does it mean about maintaining principles while adapting practice? So care delivery with individualized plans versus population-focused screening. So you still had to maintain patient safety and dignity. What about procedures? Well, procedures could move from full sterile technique and full documentation to clean technique and essential documentation. So, but you always maintained basic infection control. What about supplies? Well, supply use may go from single-use items to reusing or improvising when it was safe. So you had to consider the effectiveness of an intervention and the safety. And then personnel, you went from specialized credentialed roles to tasks being reassigned under supervision. When disasters overwhelm resources, health professionals must make difficult decisions about how to allocate those resources. These decisions are not about abandoning care. Instead, they focus on maximizing survival when resources are limited. Triage and resource allocation, therefore, become central components of disaster nursing. 4 principles guide care when resources are limited. First is survival care education, which teaches communities basic self-care and first aid. Second is triage, which prioritizes patients according to severity and likelihood of benefit. Third is economic use of resources, ensuring that supplies and personnel are used effectively. And fourth is effective planning and training, because preparedness determines response effectiveness. I always want to tell people when we talk about the importance of training is that you wouldn't expect, if you were playing basketball, to be good as a team if you never played together and you never practiced together. We play as we practice. Triage prioritizes patients when resources are limited. Immediate patients require life-saving treatment right away. This would be things like airway obstruction or severe bleeding or shock. So these are high priority. Delayed patients have serious injuries, but they can wait. Things like fractures or lacerations or moderate burns. Minor patients require minimal care. Those are people that may have superficial wounds, sprains, or abrasions. They can probably care for themselves if they needed to. And then expectant patients have injuries that are unlikely to survive given the available resources and may receive comfort care. The final category, obviously, is the most ethically challenging aspect of disaster response and disaster triage. Allocation in practice means modifying care. It means grouping protocols versus individualized plans. It means modifying procedures, clean instead of sterile. It means personnel reallocation, RN supervised basic care tasks that may be done by others. And then it means supply conservation, reusing equipment after a proper decontamination. So let's talk a little bit about the incident command system, and we'll just go through this briefly. Large disasters involve many organizations, including hospitals, emergency medical services, fire departments, law enforcement, and public health agencies. Without coordination, these responses can become chaotic. The incident command system was developed to provide a standardized framework for managing emergencies. The incident command system was developed after major wildfires in California during the 1970s. Multiple jurisdictions responded, but they lacked a unified communication and coordination system. ICS introduced standardized structures, unified command, and clear relationships. Today, it is used for all disaster types. Healthcare professionals must understand ICS for several reasons. Emergency responders may request medical expertise at disaster scenes. Public health functions operate within federal disaster response structures, and healthcare organizations also are required to integrate emergency plans with community response systems. We all need to be able to speak the same language. It isn't just that Joint Commission requires healthcare organizations to integrate with community command structures, but we need to be able to be our most effective during a disaster. ICS contains 5 functional areas. Incident command provides the overall leadership. Operations manages tactical response. Planning collects and analyzes information. Logistics provides supplies, facilities, and services. Logistics are also the ones that arrange your travel arrangements if you're going on a deployment. And finance and administration track the cost and the contracts. Nurses are most often working within the operations section, but they can contribute to all of the sections. In addition to local and state systems, the federal government maintains national preparedness resources. One of the most important of those resources is the Strategic National Stockpile. The Strategic National Stockpile, or the Pharmaceutical Stockpile, and its name has changed multiple times, is a large reserve of medical supplies and pharmaceuticals for public health emergencies. These supplies are used when local resources are exhausted. Stockpile assets can reach any location in the U.S. within approximately 12 hours of a federal deployment. It's really interesting because there's been a big evolution from what was in the stockpile in the civil defense era and what was there now. In the 1950s and 60s, there were civil defense caches all over the country, but they had very little in them. And then in 1999, there was the National Pharmaceutical Stockpile was established, and in 2003, it was renamed the Strategic National Stockpile. And it's currently managed through ASPR, whose name also changes regularly, and the CDC. And the location of who manages what has changed over time, and I'm sure in your lifetime it will continue to change. One of the important things to know is the people that work with the stockpile are highly trained. And if you ever have an opportunity to do the training for when a strategic national stockpile or pods or anything else is delivered to your community, I think you should, as a nurse, consider it a civic responsibility to do that. It's important to know, and I know many of you were not born then, after 9/11, when we had the attacks on the World Trade Center and the Pentagon, and then it was important to know that there was a point in time when, other than military planes that were flying, the only other 2 planes in the air were the President of the United States and the Strategic National Stockpile, going to where it was needed. This is a duty. You should consider it as a duty to know how it works. The stockpile includes medications, vaccines, ventilators, personal protective equipment, and diagnostic supplies. The resources allow communities to establish temporary treatment facilities in locations such as schools and communities. One of the things I would like you to take the time to do in this module is to fill out this slide. To go through, you can look this up online. Google that. Look up what's in the Strategic National Stockpile. What does the pharmaceutical cache include? What's there for chronic disease management, for acute and infectious diseases, for prevention and protection? What are the medical supplies that are there? What are the clinical care supplies, the patient support supplies, the facility infrastructure? What's there in terms of quarantine support? Take time to look this up. It will be a good exercise, and you will remember it much better than if I just told you the answers. Although as the semester goes on, we'll tell you the answers. Children is an issue that I think is really important for you to understand. Children represent about a quarter of the United States population, yet emergency response systems are often designed primarily for adults. For this reason, disaster planning must consider the unique needs of children. Children have several vulnerabilities during a disaster. Now, if you've already been trained in pediatrics in your courses, you're going to know this. But children breathe faster and they absorb toxins more quickly. They have difficulty understanding communication instructions, and they also have a harder time communicating their symptoms. And they depend heavily on caregivers and may be vulnerable to family separation. So when we refer to children, we're referring to people that are under the age of 13. If they're from 13 to 23, they're considered adolescents. There are 73.7 million children in the United States. So the challenge is that children are a distinct population with needs based on their developmental stage and cannot be treated as a unified group. Children are not little adults. They often require specialized resources that are not found in adult-focused emergency systems. You will largely see when you get caches of supplies adult dosages, not dosages for children. So physiologically, remember this, higher respiratory rates increase inhalation risk. Thinner skin enhances chemical absorption, and their small body mass means faster symptom onset. There are developmental differences. They have a limited ability to articulate their needs and their symptoms. They cannot make informed safety decisions, and they are more highly dependent on parents and caregivers. They have behavioral differences. They tend to touch surfaces and their mouth. This is a problem in certain types of events. And they may not understand or follow safety instructions. And then finally, they tend to be afraid of strangers, and that may prevent them from seeking help. And some social and logistical differences. Evacuation plans may not include the needs of children. We have worked really hard over the last 20 years to correct this, but it is still a problem. There is risk of prolonged separation from their families, and there's an increased risk of them being abducted, abused, or neglected during a disaster. It is a problem in every disaster, so their safety is critical. Children may also experience psychological stress following disasters. Common reactions include anxiety, sleep disturbance, regression, and separation anxiety. So, as nurses, you can support children by providing reassurance, maintaining routines, and supporting both the children and their caregivers. So, what are some of the things that cause psychological reactions? Well, there's a lot of stress in a disaster. The evacuation is chaotic. You can lose family and they can lose pets. There is destruction of their homes, so they've lost what's familiar, and separation from their community and their friends, not to mention disrupted routines. Some observable reactions that you might expect to see in children would include regression, so bedwetting, separation anxiety, hypervigilance, difficulty sleeping. They may be afraid of things they've never been afraid of before, and then they may reenact the event over and over again. You need to know about the legal resources that are available and what you need to do legally. First of all, as a nurse, you're a mandatory reporter, as are social workers, most healthcare professionals, and law enforcement, teachers, and mental health staff. So, helpful nursing responses can include giving simple, realistic answers to children, clarifying things when they have distorted realities, gently reassure them and clarify them, be sensitive to environmental cues, and support the parents and the child together. And then some of the reunification resources you need to know about. Absolutely, the American Red Cross Safe and Well and the National Center for Missing and Exploited Children. Look up both of those. Make sure you know what they are and how you would reach out to them in a disaster. At this point, it's helpful to step back and to integrate the major concepts that we've discussed. Effective disaster response requires understanding disaster phases, triage, principles, response coordination, systems, and the need of vulnerable populations. As nurses, you play a critical role throughout this entire process. So let's briefly review some key questions in which the phase of disaster life cycle and where nurses can be most effectively used to reduce long-term impacts. So what do you think that is? So which disaster phase can nurses best reduce long-term health impacts and why? Why don't you take some time to answer this for yourself? Write down what you think the answer is, and then you can share it on Canvas, or you can share it in the comments on YouTube. The next question is, where are nurses most commonly positioned within the incident command system? Do you remember the answer to that one? If not, take time to go back and find the answer. And then the last question is, why do disasters affect children differently than adults? And remember, children are not just small adults in disasters. So how does this change your approach to them during a disaster? These are questions that after this module, you should have been able to answer really quickly. Finally, I encourage you to explore additional resources. FEMA offers training courses in the Incident Command System. Organizations such as Emergency Nurses Association and the American Red Cross provide additional disaster training. And understanding these systems will strengthen your ability to respond effectively during a public health disaster. I have listed here some resources for you, both federal disaster response resources and specialized nursing and child resources. I hope that you enjoy the courses. This was your lecture 1. There is a part 2, which will follow. You should take a break and then come back. Thank you.